Hello, I'm Dr. Elliott Antman, President of the American Heart Association. We're here at the American Heart Association's Scientific Sessions in Chicago. I'm pleased to be joined by Dr. Mark Creager, our President-elect, and Dr. Robert Harrington, the Chair of our Committee on Scientific Sessions program. This has been a jam-packed meeting with lots of very interesting science, and I think we'll hit some of the highlights by looking at the late-breaking clinical trials. So the very first one that I think we should talk about is the dual antiplatelet therapy trial. And Bob, this was a public-private partnership arrangement. You want to say a little bit about what that means?
Well, this trial had its beginnings back in 2006 when it was reported at the European Society of Cardiology meeting that there was this excess of late stent thrombosis following DES implantation. This certainly got a lot of people concerned and got a lot of people doing additional observational work because there had been no randomized data to help guide practice. The FDA convened an advisory committee to look at the question. Everyone literally from around the world who had data brought it to that advisory committee meeting. What came out of that is that the FDA convened a group of device and drug manufacturers and asked them to join with them in a public-private partnership. So the public part being the FDA, the private part being the manufacturers, to do a clinical trial and answer the question. Laura Murray from our Harvard Clinical Research Institute and the Brigham and Women and Dean Kariakis from Cincinnati were chosen to lead the effort to put this trial together. And they did it. And it was guided along the way in a very interesting way by this coalition of companies and the FDA.
So let's talk about the highlights of what we learned there. We learned that prolonged dual antiplatelet therapy after 1 year, continuing for another 18 months, for a total of 30 months, was better than stopping after a year at preventing cardiovascular events. There was this interesting question that arose about an increase in mortality in the patients who did receive the prolonged dual antiplatelet therapy. A lot of discussion about that. It appeared to mostly be related to an excess of cancer deaths, which was probably largely explained by the known cancers before patients entered the trial. Now, Mark, when we looked at the benefits of prolonged dual antiplatelet therapy, there were reductions in events which made people talk about not only preventing stent thrombosis, but some coronary events that were distant from the stented area. And we started to hear a little bit about the discussion about the prolonged dual antiplatelet therapy actually doing some secondary prevention from an atherosclerotic perspective. Any thoughts?
Exactly right, Elliot. That's important information that's coming out from this trial as well. And in fact, it's not that surprising because we've had previous trials that have looked at dual antiplatelet therapy with aspirin and ethinopyridine in patients with established atherosclerosis. The Charisma trial is one of them. And if you look at the subset of patients who had established atherosclerotic disease, coronary artery disease, there was a reduction in adverse cardiovascular events. And in this trial as well, the DAP trial, we found that there was a reduction in myocardial infarction that was not just explained by a reduction in stent thrombosis. And of course, that makes sense as we think about the biology of atherosclerosis. In fact, in another trial using Vorapaxar published recently also showed that additional antiplatelet therapy was effective in reducing cardiovascular events in patients with atherosclerosis. So the findings are consistent among these trials.
I heard one question from our discussants about whether or not we should ever stop dual antiplatelet therapy in a patient in whom we've made the decision to put in a stent. That's going to require more analysis, more conversation. We will have the benefit of a simultaneously published paper in the New England Journal of Medicine, and incidentally also a meta-analysis about this issue about cancer risk. That was put online in Lancet. The FDA sent 3 representatives as discussants to this. That was highly unusual for us there. And Bob, you want to talk about what they were interested in?
Well, I think they were interested in a couple of things, one of which is that they were certainly interested in highlighting that they were involved in this through this public-private partnership mechanism. It's a very unusual way, as you know well, to do a trial, and I think they wanted to highlight that. They are not quite ready to discard this, this late mortality observation until they look more at the data. They've seen the published data, but rightfully the regulatory agencies want to dig into it themselves and get a little more information. I thought the investigators, Laura Mowry, did a fabulous job of walking us through the likely confounding by the imbalance of cancer at baseline, and I thought she did a nice job highlighting this meta-analysis that they put together quickly to see where the cancer finding lived in the total amount of data that's available. And as you've rightly pointed out, Elliott, it doesn't appear when you look at all the data that there's this excess risk. But I think rightfully the FDA wants to tear into the data a bit more themselves.
Absolutely. And one very important thing that those viewing this recording or those who might look at the FDA website and see their safety announcement, they use the word preliminary, and let's not be confused about that. The results that were presented here at Scientific Sessions are the final results from the DAPT investigators, and the New England Journal paper is the formal scientific paper that actually describes those final results. The FDA spoke about the word preliminary, or used the word preliminary from a regulatory perspective. They have not yet had the opportunity to review the original database that will be submitted to them, so they haven't had a chance to replicate the findings. And so from their perspective, it's preliminary. Their statements are preliminary. So let's just be clear about that. Let's move on to the trial that everybody was talking about on day 2, which was the Improve It study. So Mark, why don't you describe the rationale for doing a study like Improve It? We had Prove It, and then this was Improve It.
Okay, and Improve It is, as you know, is a trial that came out of the TIMI study group, and really was testing the LDL lowering hypothesis. Does lowering lipid levels favorably translate into improved cardiovascular events? And in this trial, patients with acute coronary syndrome were enrolled and randomized to simvastatin, initially 40 milligrams per day, or simvastatin plus ezetimibe, 10 milligrams per day. And patients who were enrolled in this trial did not have very high levels of cholesterol. Actually, they had moderate to low levels of LDL cholesterol, which enabled them to be eligible for enrollment. And the patients were followed for an average 6 years. And the findings demonstrated that the combination of simvastatin plus ezetimibe decreased the risk of a composite of adverse cardiovascular events. Now, it was intriguing that the levels achieved were low in both groups, under 70 milligrams per deciliter in those randomized to simvastatin alone. And admittedly, some of those who initially got 40 milligrams, it was bumped up to 80 milligrams per day. And it went down to 59 milligrams per deciliter in those.
54, I think.
Thank you. Thank you for being more
It's
precise.
about a 15 millimeter.
54 milligrams per
point difference.
deciliter
Yep.
in those patients who got the combination therapy. And in those who got combination therapy, there was an approximate 6.4%, if I can be as precise as possible, in the risk of these adverse cardiovascular events. So what we have here is lower is better in reducing the risk of these cardiovascular consequences in patients at high risk for cardiovascular events, those who've had acute coronary syndrome.
And maybe one other point to add, which is that this is the first example where a non-statin therapy given to a group of patients with LDL, lowering out through a lowering LDL mechanism was associated with cardiovascular outcome benefit.
So we learned, we reinforced our statements that lowering LDL is good. Lowering the LDL even further seemed to be even better, and in this case, with a non-statin. Now, Bob, talk about the fact that there were over 5,000 primary endpoint events in this cardiovascular trial. That's a pretty large number.
So Chris Cannon did a good job, I think, of walking us through the study rationale, which Mark has nicely outlined. And what Chris pointed out is that ezetimibe has a modest effect on reducing cholesterol. It was anticipated that there would be this 14, 15-point drop in LDL cholesterol. And if the cholesterol trialist meta-analysis of the relationship between LDL lowering clinical events was accurate and was going to continue to play out at this level of LDL, it was going to require over 5,000 events to have 90% power to detect. They were looking for a 9% absolute relative risk reduction. So they anticipated a relatively modest relative risk reduction because that's what the LDL lowering effect would have anticipated.
Yes. This trial's not without some controversy all along until we heard the results. And I think a lot of people were saying the approval of ezetimibe was based on a surrogate endpoint, which was lowering LDL, and they didn't really buy into using it until they saw the clinical outcomes trials such as this one here, Improve It, and I think they're quite satisfied with the findings. Talk a little bit about surrogate endpoints. So, Mark, how solid was the LDL lowering evidence with respect to prevention of events? If we started with WASCOPs and go way back.
Well, if we look at an entire lineage of cholesterol-lowering trials over time, starting with things like a WASCOPS,
Yes.
where the LDL cholesterol was very high, to this trial, the Improve It trial, where the LDL cholesterol was relatively low, we know that the rate of improvement in cardiovascular events is greatest in those who are treated from the higher levels to a lower level. And if we follow that line all the way through its end, the Improve It trial fits perfectly on it. So the actual reduction in cardiovascular events is just what would have been anticipated for the starting level of LDL cholesterol. And again, consistent with the lipid-lowering hypothesis.
This was not an easy trial to do because it went on for many years and it was double-blind. So I think that was great. It was actually a joint effort, I think, Bob, between the TIMI study group and DCRI, right?
Yeah, this was a collaboration between the two academic research groups at TIMI and at Duke, and it was a difficult trial to do. And I think Dr. Brunwald said at the investigator meeting, this trial took several bullets and survived to the end. Yes. And some of the bullets it took along the way, if you remember, there was this cancer scare. Yes. In another clinical trial, which raised all sorts of questions. Well, what's going on in Improve It? One of the things that came out at the panel discussion this week from Neil Stone was, it's very nice to have this 6 years of follow-up that Mark references, because we know during that 6-year period of ezetimibe treatment, there was no increased risk of cancer. Carefully looked for, carefully adjudicated, et cetera.
There were actually two presentations. One was the intention to treat analysis, which was the main one, and then there was something called the on-treatment analysis. Can you just quickly tell the viewers the difference between those two?
Yeah, this is particularly important in chronic therapy trials, where over the course of time, just like in clinical practice, patients stop taking their medications for a variety of reasons. This trial went on for a long time, as we've just noted, and in those kinds of trials, large numbers of patients frequently don't take their medication for a variety of reasons. And in this particular case, it was almost 50% of the patients in both treatment arms who were not taking their medication. Now, in an interpretation of the trial, the most conservative way to look at the trial is the intention to treat. If you were randomized, you're counted. No matter what, if you never took the drug, you're still counted. If you came off the drug, you're still counted. And that preserves the balance at randomization so that you can appropriately compare the two groups. In a non-treatment analysis, it's just what it says. It's doing the analysis during that period of time, including those patients when they're actually on the therapy. That's a little more challenging because people come off the therapy for a variety of reasons that might be influenced by the therapy itself. So you've lost sort of the benefit of randomization at that point. What Mark had pointed out, 6% relative risk reduction in the primary intention to treat analysis. In the on-treatment analysis, it's more in the 8 to 9% range, which is spot on what Chris had presented as the anticipated treatment effect based on, as Mark said, the assumed LDL lowering.
So they're supportive of each other, they're internally consistent, which is always good.
And they were what was expected.
All right, so let's have just a few comments about some other interesting trials. One was a primary prevention study with aspirin in Japan, and these were patients who were supposed to be high risk. And Mark, what were your thoughts about that one?
Another important study coming out of Sessions. So this was a study, as you mentioned, Elliott, that took place in Japan. It was in elderly individuals who were at risk for atherosclerosis but did not have established atherosclerosis. And they were randomized to placebo or low-dose aspirin. And the intent was to determine whether or not the use of aspirin in these individuals would reduce their future risk of a cardiovascular event. And this was a negative trial. Now, it supports many other trials in primary prevention with aspirin, and one might say is putting another nail in the coffin of the use of aspirin for primary prevention. So it's something we need to really think about. What patients will benefit from antiplatelet therapy in general and aspirin in particular, and should be restricting its use to those at the highest risk, and particularly those with established vascular disease.
The one remaining question I have about that study and its findings is the duration of follow-up. And as you mentioned, those individuals who start with the highest risk when you talked about LDL will have the greatest benefit. So these are lower risk individuals. This was a primary prevention study. So I would imagine it would take years, if not decades, for atherosclerosis to develop in those individuals. And I just had a residual question about whether or not they followed a long enough period of the time horizon of the biology of the disease. And any thoughts on that?
Well, it does take into consideration whether one would use any therapy in a low-risk population and how many people you have to study and for how long you have to study them, whether it be lipid-lowering therapy or antiplatelet therapy. But nonetheless, the lower the risk the population, the numbers needed to treat becomes much, much higher.
Yes.
And then you have to take into consideration the safety of your treatment.
Yes.
And aspirin, though effective in many situations, is not necessarily just a benign drug. There's obviously increased risk of bleeding, and particularly in populations such as those studied in Japan, the elderly. So I think it's an important question, it's an important concern, but taking this trial and putting it in context with other trials of aspirin and primary prevention, we're seeing very little evidence, virtually none, that the use of aspirin for primary prevention is an effective therapy.
So this was important information here as well. We had 2 positive trials, DAPT and IMPROVE IT. This is an important negative. And the last set of trials both dealt with a drug called losartan, and this had to do with patients with Marfan syndrome and individuals who had hypertrophic myopathy. And Mark, why did people even begin to study losartan and Marfan syndrome? What was the biology there?
Well, both trials, again, in very important trials. And very pleased that they were presented here at the American Heart Association Scientific Sessions. So there's been some wonderful science in the area of Marfan syndrome, conducted primarily by Hal Dietz and his colleagues in preclinical models that have really examined how the fibrillin-1 mutation, which is the cause of Marfan syndrome, affects TGF-beta signaling. And it's also known that angiotensin receptor blockers impair TGF-beta signaling. So in preclinical models, Dietz and colleagues have shown that it reduces the expansion of the aortic root and complications. So it's important to translate this information from the bench to the bedside. And there was this trial was conducted by the Pediatric Networks. Did I say that right?
Pediatric Trials Network,
Pediatric,
NHLBI.
correctly.
Right.
And it involved children and young adults who were randomized to losartan or the traditional therapy, a beta blocker, atenolol. And the primary endpoint was the rate of change in the aortic root size. And it turned out that in both those treated with losartan and those treated with atenolol, there was a decrease in the rate over time. But there was no difference in the slope between the 2 treatment groups.
Okay, and tell us about the losartan study with hypertrophic myopathy.
So this is a trial, as you mentioned, in people who had clinical evidence of hypertrophic cardiomyopathy, in which there's really no established evidence-based therapies that favorably affects outcomes. There's things we do. We give beta blockers to these patients. Some get surgical procedures. Some get catheter-based ablations. Right, but there's nothing that's been really shown to affect outcome. And in a hypertensive population, those with left ventricular hypertrophy, it's been shown that angiotensin receptor blockers decrease left ventricular wall mass. So the question is, will that be translated or in patients with hypertrophic cardiomyopathy? So this was a trial comparing losartan to placebo in patients with clinical evidence of hypertrophic cardiomyopathy. The results were negative. There was no difference in left ventricular wall mass and a number of secondary endpoints as well. Now, I will say that this does not mean that an angiotensin receptor blocker is not effective in all patients with hypertrophic cardiomyopathy. A problem with this study, if you will, is that they did not do genetic analysis in the majority of patients. And it may be if we targeted those individuals who have sarcomere mutations,
Might see
specifically, you might be able to demonstrate a benefit. And in fact, a trial like that is being planned.
And you know, that makes me think about something else that was really discussed a lot at this meeting, which was the cardiovascular genome-phenome study that the American Heart Association has played such a pivotal role in starting. And maybe in the future we'll see just the kind of information you're referring to. I want to ask Bob to comment towards the end here about the fact that the Marfan's Foundation was so instrumental in this trial of losartan. They really wanted to see this trial. Talk about that a little bit.
Well, Mark has nicely described the importance of these trials. Let me just add my perspective that we need trials like this. These are small patient populations that don't typically get studied in randomized trials. And so what happens that a lot of the decision making is based on anecdote, some observational data, some mechanistic underpinnings that people say, well, that makes sense, I'm going to do this. To the credit of the patient advocacy group who have themselves patients or family members who are patients with Marfan, they recognized that there was a shortage of evidence in the field, and there was an increasing usage of losartan in the field. And rather than say, that's okay based on the mechanism and the preclinical data, they said, we want to be in the clinical trials. And the Marfan patient advocacy group really supported the Pediatric Trial Network to get the trial done. Really great interaction between the patients and the investigators.
We need to see more of that.
Much more of it.
Bob, I'd be remiss if I didn't, as president, thank you for the effort as chair of the program committee for the last 2 years, and what a marvelous meeting you put on. You want to tell folks what your red sneakers are all about today?
Yeah, you've noted that Dr. Creager and I are sitting here wearing our running shoes today, and part of it is that the Chicago Convention Center is a big place. We're running around. But on a serious note, on Tuesdays at the American Heart Association, we've started something last year, which is wear your sneakers for heart health. And we encourage attendees at the meeting to wear sneakers. Remember that one of life's simple 7 is physical activity and the relationship of physical activity to improved heart health. So it's nice to walk throughout the convention center and see a lot of our colleagues wearing their suits and their running shoes. So thanks to you, Elliott, for supporting it as the president. And Mark, thanks for setting a good example as the president-elect and wearing your running shoes.
Terrific discussion. I thank you both. And this is Elliott Antman for AHA Science News here in Chicago.